Welcome to this video entitled, Clinical Aspects of Intracerebral Hemorrhage. As a way of introduction, stroke is the second most frequent cause of death in the world, with 6.7 million globally documented cases in 2012 alone. This chapter focuses on intracerebral hemorrhage, abbreviated as IC, the least common type of stroke, accounting for about 13% of all stroke victims, occurring at an annual rate of about 12 to 15 cases per 100,000 people. Despite having the lowest incidence of any type of stroke, the mortality rate exceeds 30% and only 1/5 of patients make a meaningful recovery to independence, making this an incredibly morbid, costly, and high-impact disease. In this chapter, we review the basic classification, clinical presentation, radiographic findings, and management of patients with intracerebral hemorrhage. Next, we will discuss the classification of stroke. Strokes are divided into two main categories: ischemic and hemorrhagic. In ischemic stroke, diminished blood flow leads to inadequate oxygenation of brain parenchyma and neuronal infarction. Hemorrhagic stroke occurs most often due to vascular injury resulting in hematoma formation and local mass effect on surrounding neural tissue. Intracerebral hemorrhage is made up of a range of pathologies with different natural causes, workup, and management, as shown in Table 92.1. It is important for clinicians to recognize the major types of intracerebral hemorrhage in order to choose the appropriate diagnostic studies and treatment options. Intracerebral hemorrhage is categorized as primary or secondary depending on etiology. Primary intracerebral hemorrhage has a higher incidence and consists of two major diseases: cerebral amyloid angiopathy, abbreviated as CAA, and hypertensive hemorrhage. Together, these two entities are responsible for greater than 80% of intracerebral hemorrhage, with hypertensive hemorrhage implicated in about 55% of total intracerebral hemorrhage cases. Hypertensive hemorrhage occurs most often in the deep regions of the brain such as the basal ganglia, thalamus, pons, and cerebellum, as shown in Figure 92.1. Chronic hypertension causes lipohyalinosis of small arteries and arterioles. Hyaline, collagen, protein, and fat replace arterioles' smooth muscle, thin the adventitia, and eventually form atheromas. The stiffened and narrowed lumen results in small areas of brain ischemia followed by encephalomalacia known as lacunes. This term is derived from the Latin word, lacunae, which appropriately means, lake. In addition to an increased risk of ischemic events, weakening of the tunica media at vessel bifurcations leads to a 2% annual risk of hemorrhage in patients with chronic hypertension. Furthermore, the weakened muscular layer is unable to vasoconstrict in response to local hemorrhage, resulting in continued bleeding and intracerebral hemorrhage progression. Previously, it was thought that weakened arterial walls form Charcot-Bouchard microaneurysms that rupture leading to hemorrhage. However, it has since been shown by electron microscopy that these microaneurysms are actually miniature hematomas located in the subadventitial or extravascular spaces. Cerebral amyloid angiopathy results from deposition of beta-amyloid proteins into the media of small meningeal and cortical vessels. These proteins exhibit apple-green birefringence upon exposure to Congo red stain under polarized light. Cerebral amyloid deposition occurs over time and has been found in about half of all patients over 70 years of age. Over time, the amyloid proteins replace the smooth muscle cells found in arteries, leading to decreased compliance and an increased bleeding risk. The annual recurrent hemorrhage rate is as high as 10.5%. Apoprotein E2 and E4 are two alleles that have been implicated in predisposition to amyloid angiopathy, with the E4 allele being associated with increased mortality and a younger age of initial intracerebral hemorrhage. Secondary intracerebral hemorrhage encompasses a wide range of pathologies, as reviewed in Table 92.1. Although it encompasses many more diseases, the overall incidence of secondary intracerebral hemorrhage is much lower than primary intracerebral hemorrhage. Each of these diseases has a unique presentation, workup, and management. Traumatic intracerebral hemorrhage, or hemorrhagic cerebral contusion, occurs most commonly in the frontal, temporal, or occipital poles due to acceleration or deceleration injuries that cause these regions to strike against the bony prominences of the cranium. In patients with severe contusions, there is a risk of delayed blossoming of the intracerebral hemorrhage, which may occur within 72 hours of the injury, leading to mass effect, edema, and rapid neurological deterioration due to elevated intracranial pressure, abbreviated as ICP. The presence of a tumor can drastically alter diagnosis and management of intracerebral hemorrhage. The frequency of spontaneous intracerebral hemorrhage from a cerebral neoplasm averages 2 to 3%. However, this can be much higher with certain types of tumors. Intraparenchymal hemorrhage from vascular lesions is most often caused by arteriovenous malformations, abbreviated as AVMs, or cavernous malformations. The annual hemorrhage risk of an unruptured arteriovenous malformation is about 2 to 4%, and as high as 7.45% in patients who have bled previously. Cavernous malformations have a lower propensity for bleeding with annual rates of less than 1% for incidentally found lesions, 2% for symptomatic lesions not related to hemorrhage, and 4.5% for lesions with symptomatic hemorrhage. Anticoagulation is often used to reduce venous and arterial thromboembolic risk in patients with certain cardiac, stroke, or malignancy histories. Common conditions include atrial fibrillation, implanted vascular stents, prior strokes, deep vein thrombosis, pulmonary embolism, and inherited or acquired coagulopathic states. Oral anticoagulants have been associated with a 10-fold increased risk of intracerebral hemorrhage in patients over 50 years, of which 60% are fatal. These hematomas have a larger volume and risk of continued expansion when compared with other causes of intracerebral hemorrhage, as shown in Figure 92.2. Novel oral anticoagulants appear to have a more favorable profile of reduced hemorrhagic risk, but have yet to be as frequently prescribed as traditional vitamin K antagonists. Pause the video and carefully scrutinize Table 92.1 summarizes the causes of intracerebral hemorrhage before advancing to the next slide. Pause the video and carefully scrutinize Figure 92.1 illustrating the anatomic distribution of intracerebral hemorrhage before advancing to the next slide. Pause the video and carefully scrutinize Figure 92.2 illustrating a gentleman in his 5th decade of life with a history of deep vein thrombosis or pulmonary embolism taking Coumadin presented with progressive lethargy and decreased responsiveness before advancing to the next slide. Pause the video and carefully scrutinize Table 92.2 summarizing the locations and presentations of intracerebral hemorrhage before advancing to the next slide. Next we will discuss the clinical presentation of stroke. It is important to remember that no single presentation encompasses all patients with intracerebral hemorrhage, as there are various causes of this disease. As with all patients with neurological disease, The location of the injury is often the most important factor in determining presentation, as shown in Table 92.2. However, the classic description of intracerebral hemorrhage is that it occurs during the daytime with a smooth and progressive onset as the volume of the hematoma expands. This is in contrast to an acute ischemic stroke with symptoms that present as both sudden and maximum at onset due to vessel occlusion. Intracerebral hemorrhage is associated with severe headache, that is 40%, and vomiting, that is 50%, eventually leading to worsening focal deficits related to location of the hemorrhage, and ultimately can result in cerebral herniation, coma, and death. Hypertension is noted in up to 90% of intracerebral hemorrhage patients as part of a classical triad seen in elevated intracranial pressure. Seizures indicated by a sudden change in examination with stable cranial imaging might also occur following intracerebral hemorrhage. Late deterioration may occur days to weeks later due to late re-bleeding or delayed hydrocephalus, which is more common in cases of intracerebral hemorrhage with associated intraventricular hemorrhage, abbreviated as IVH, due to impaired cerebrospinal fluid reabsorption. We will now progress to the radiologic findings. The first-line imaging obtained for patients with intracerebral hemorrhage is head-computed tomography, abbreviated as CT. It is both fast and ideal for showing acute hemorrhage as a hyperdense mass relative to brain parenchyma. This allows the clinician to immediately differentiate hemorrhage from ischemic stroke. It also shows acute structural complications such as herniation, intraventricular hemorrhage, or hydrocephalus that may require emergent treatment. As intracerebral hemorrhage patients are often acutely ill and at risk of rapid decompensation, a head CT allows for quick assessment and decision-making regarding further diagnostic course, prognosis related to clot burden, and subsequent treatment decisions. The rate of re-bleed within 24 hours has been shown to steadily decline with time, starting as high as 30% in the first 1 to 3 hours, and dropping as low as 14% within the 24 hours period between initial and follow-up scans. At our institution, we repeat a head CT at 6H from initial imaging in non-operative patients to ensure hematoma stability. We follow the same imaging protocol for patients with traumatic cerebral contusions as well, although data by Anandalwar and colleagues in 2016 suggest that in certain cases of minimal head injury with intracerebral hemorrhage, observation is sufficient in lieu of repeat imaging. Hypertensive intracerebral hemorrhages occur most commonly in areas where the arteries receive excess shear force due to high-velocity blood flow, namely at early branching points of the proximal arterial system just beyond the circle of Willis or the basilar artery. This leads to hemorrhage in the deep structures in the brain, as shown in figures 92.3 and 92.4. Unfortunately, given the fascicular organization of the brain, the highly condensed information highways that carry the majority of information are located in these deep structures, making hemorrhage in these areas particularly devastating. Cerebral amyloid angiopathy should be suspected in older patients with recurrent lobar hemorrhages. Magnetic resonance imaging, abbreviated as MRI, often demonstrates multiple subcortical microhemorrhages with dropout regions of blooming on sagittal weighted imaging, abbreviated as SWI, as shown in figures 92.5 and 92.6, highly suggestive of amyloid angiopathy. However, cerebral amyloid angiopathy may be difficult to see on standard T1 or T2 MRI imaging. Intracerebral hemorrhage patients suspected of having an underlying vascular lesion should undergo CT angiography, abbreviated as CTA, MR angiography, abbreviated as MRA, digital subtraction cerebral angiography, or some combination of these studies. Halpin et al. Examined the role of angiography in 102 patients presenting with intracerebral hemorrhage on head court. CT findings suspicious for an underlying vascular lesion included subarachnoid or intraventricular hemorrhage, abnormal calcification or location of hemorrhage, and prominent vascular structures. In 84% of these patients, an underlying arteriovenous malformation or aneurysm was demonstrated by angiography. Developmental venous anomalies can occasionally be seen on head CT, or more definitively on CT angiography, and are associated with cavernous malformations in about 20 to 25% of cases. MRI or MRA is useful in determining the age of blood products and can detect cavernous malformations, which are occult on cerebral angiography. MRA is also more sensitive than CT angiography at detecting dural arteriovenous fistulas, due to signal saturation of the skull at the dural surface in CT. If no lesion is seen on the initial round of imaging workup, a delayed contrast MRI is often performed 6 to 8 weeks following the initial hemorrhage so that after hematoma reabsorption, vascular lesions may be more readily identified. Figure 92.7 depicts a ruptured mycotic aneurysm, which classically occurs in those with a pathological heart valve and bacteremia. An echocardiogram may show vegetation on the abnormal valve. Mycotic aneurysms are typically located in the distal arterial branches, rather than the proximal vessels seen most often in classic cerebral aneurysms. A tumor can sometimes be seen on CT scan as a non-hemorrhagic hyperdense lesion within the hyperdense intracerebral hemorrhage. Occasionally, surrounding edema is noted as well. These findings, unusual hemorrhagic locations, or a suspicious history, e.g., a cancer history, warrant an MRI with contrast to rule out tumor as the possible cause of hemorrhage, as shown in Figure 92.8. If no lesion is identified on initial MRI, but there remains suspicion for a neoplastic etiology, a repeat MRI should be performed in 6 to 8 weeks, as acute blood products can obscure an underlying tumor. Pause the video and carefully scrutinize Figure 92.3, illustrating a woman in the 6th decade of life with a history of chronic hypertension, diabetes mellitus, coronary artery disease status post-coronary artery bypass graft, and on lifetime aspirin 325 mg daily, was found unresponsive with a systolic blood pressure of 220 by first responders before advancing to the next slide. Pause the video and carefully scrutinize Figure 92.4, illustrating a gentleman in his 8th decade of life with a history of chronic hypertension, presence with progressive lethargy, dysarthria, right-sided weakness and right facial droop before advancing to the next slide. Pause the video and carefully scrutinize Figure 92.5, illustrating a woman in the 9th decade of life with a history of atrial fibrillation and deep venous thrombosis treated with Coumadin, presented with right facial weakness and slurred speech before advancing to the next slide. Pause the video and carefully scrutinize Figure 92.6, illustrating a woman in the 9th decade of life presents a year after right frontal intraparenchymal hemorrhage with new weakness and aphasia. Before advancing to the next slide. Pause the video and carefully scrutinize Figure 92.7, illustrating a gentleman in the 5th decade of life was found unconscious before advancing to the next slide. Pause the video and carefully scrutinize Figure 92.8, illustrating a woman in the 7th decade of life has a history of non-small cell lung cancer with known metastases to the brain and vertebral column, who has undergone whole brain radiation therapy, presented with left hand and leg weakness before advancing to the next slide. We will now progress to the management of intracerebral hemorrhage. Management of intracerebral hemorrhage is a nuanced topic that requires a complete understanding of the patient's health prior to the inciting event, as well as their prognosis and desired quality of life. One must gather as much information as possible from the patient, close contacts, neurological examination, laboratory data, and imaging findings when deciding upon management. Unfortunately, intracerebral hemorrhage is a highly morbid disease with a paucity of strong data supporting current medical and surgical treatment strategies. Hemphill et al. Introduced an intracerebral hemorrhage scoring system in 2001 to predict 30-day mortality, as shown in Table 92.3, which can help guide clinical decision-making. In 2015, the American Heart Association and the American Stroke published an up-to-date treatment guideline for clinicians. We summarize the major concepts in the following paragraphs. The initial goal of treatment is to reduce the risk of acute re-bleed and treat any pathology leading to immediate mortality. Blood pressure control and reversal of coagulopathy are priorities in acute hemorrhage. In parallel with these goals, emergent management of intracerebral hemorrhage is a priority and may include the use of intravenous mannitol or hypertonic saline. In patients with depressed consciousness, such as a Glasgow Coma Scale, abbreviated as GCS, of less than 8, rapid intubation provides both airway protection and a means of respiratory control. With secured mechanical ventilation, the patient can be hyperventilated, causing cerebral arterial constriction, thereby reducing intracranial pressure, and also safely receive sedating and paralyzing medications to decrease cerebral metabolic demand. A bedside external ventricular drain may be necessary in patients with acute hydrocephalus. Decompressive operations are an option in select patients who are acutely decompensating, and can sometimes be combined with clot evacuation. Upon stabilization, admission to a neurological ICU for close observation and medical optimization is warranted. To reduce the risk of re-bleeding, strict blood pressure parameters are maintained with attention to premorbid perfusion dependency. Maximizing hemostatic ability, including optimization of coagulation factors, and platelet count and function, are equally important. In patients with thrombocytopenia, or using antiplatelet medications, platelet transfusion helps to form the initial platelet plug that acts as a scaffold for clot formation. Following formation of a platelet plug, coagulation factors have a major role in clot stability. Patients with coagulopathies such as those with liver disease or on anticoagulation may be given exogenous factors through transfusions of fresh frozen plasma, prothrombin concentrate complex, or even fast-acting antibodies that disable the latest generation of anticoagulants. Vitamin K should be given to those with functional livers to maintain coagulation factor production over a sustained time period. Patients with supratentorial intracerebral hemorrhage are at increased risk of seizures, and some centers will pretreat with anticonvulsant prophylaxis of set duration. In cases of an unexplainable worsening neurological examination, an EEG can be used to diagnose the possibility of seizures. Untreated seizures can lead to increased intracranial pressure, re-rupture of vascular pathologies, or accelerated herniation in mass-occupying lesions. Surgical management of intracerebral hemorrhage is a controversial topic, Yet the goals of surgery in the acute setting of decompensated intracerebral hemorrhage are straightforward: decompression, clot removal, and treatment of hydrocephalus if present. During workup of a stable patient, if an underlying lesion such as a vascular malformation or tumor is noted in the region of hemorrhage, the patient may elect to undergo surgery, with the goal being to removal to reduce risk of future hemorrhage. Aneurysmal sources represent the lesions with greatest incidence of acute re-hemorrhage. In contrast, other vascular malformations have only a slight increase in short-term hemorrhage rate, and intervention is planned according to the patient's ability to safely undergo surgery. Although there is limited data on surgical management of intracerebral hemorrhage, most surgeons prefer conservative management for deep hemorrhages, hemorrhages within vital structures, e.g., brainstem, deep white matter tracts, or basal nuclei. Low volume, 3 cm in diameter with brain stem compression or evolving hydrocephalus should be considered for emergent surgery due to the small volume of the posterior fossa and high risk of tonsillar and/or upward cerebellar herniation with hematoma expansion. Patients with large volume supratentorial hemorrhage causing shift and subsequent herniation at the level of the falx, tentorium, or foramen magnum should also be considered for emergent clot evacuation. Another group of patients who require surgery are those with accessible lesions who develop delayed neurological deterioration due to hematoma growth. To preserve function, a decompressive operation should be highly considered. For example, a middle-aged patient with putamenal hemorrhage and progressive weakness due to an enlarging hematoma compressing the internal capsule would benefit from decompression. Removal of the hematoma gives an improved likelihood of restoring function. Stage 1 and 2 are the largest randomized studies on surgical versus medical management of supratentorial intracerebral hemorrhage. The Stage 1 trial is a prospective parallel group trial that compared early craniotomy for hematoma evacuation, that is less than 30 hours after symptoms, to medical management in 1033 patients. Follow-up focused on mortality, as well as disability based on the GCS. This 5-year trial showed no benefit from early surgery when compared to conservative management. However, there was a trend toward better outcomes in those with superficial hemorrhage. This trial enrolled all patients, including those with devastating hemorrhages, e.g., patients with intraventricular hemorrhage and hydrocephalus, deep hemorrhage, or massive hemorrhage, that surgeons would usually not operate on due to predictably of poor outcomes. There were also a high percentage of participant crossovers from the medical to the surgical arm upon rapid neurological decline. Due to these criticisms, Stage 2 was initiated, almost a decade later, in a select patient group that was more likely to show benefit from surgery. Patients who were enrolled had small, superficial hemorrhage with GCS greater than 8 and no hydrocephalus or intraventricular hemorrhage. It was hypothesized that patients with these criteria would have better surgical outcomes. However, the results were once again equivocal. It is likely because the natural course of these selected patients was relatively benign, and these patients would have shown significant improvement with time regardless of management strategy. There is likely an as yet unidentified subgroup of patients who fall between those in the 2 Stitch trials who would benefit from surgical intervention. As we continue our attempts to define which patients would benefit from current methods of open surgical intervention of intracerebral hemorrhage, innovative technologies are simultaneously being developed that aim to make hematoma evacuation more expeditious and less invasive. Endoscopic clot removal devices, local tissue plasminogen activator, abbreviated as TPA, administration, and stereotactic aspiration are some of the novel methods under investigation. With the development of this new frontier of minimally invasive techniques, we hope to decrease surgical morbidity, safely gain access to deeper lesions, and improve patient outcomes. Pause the video and carefully scrutinize Table 92.3 summarizing intracerebral hemorrhage score system and prognosis before advancing to the next slide. And now in conclusion, intracerebral hemorrhage is a vast and nuanced topic with a significant impact on public health due to the associated high morbidity and mortality. It is important to have an in-depth understanding of the presentation and natural course of intracerebral hemorrhage. With improvements in preventative care and new diagnostic tests, we are reducing the incidence and time to diagnosis in cases of intracerebral hemorrhage. However, our medical and surgical treatment strategies have not improved significantly, and stubbornly high rates of morbidity and mortality persist in these patients. Continued advancements in our understanding and treatments for intracerebral hemorrhage are needed to preserve the lives and neurological function of patients who suffer from intracranial hemorrhage. Thank you.